Hey folks, my name is Dr. Amy Pearlman. I'm a board certified urologist with expertise in sexual, hormonal, and genitourinary health. And welcome to today's episode of Pearls and Perspectives. I'm joined today by Dr. Emad Ibrahim. Dr. Emad, say hello to the crew.
Hello, everyone. Nice to join you, and let's get a nice talk here.
Awesome. So you and I recently connected because I have a practice in the Miami, Florida area, and you are on faculty at the University of Miami. And I have some patients that I wanted to get in for some cryopreservation. So we connected via email and we met, and I learned about all the different things that you do for patients, not only in the local community, but you were just mentioning that you have people come in from other areas of the country for some specialized procedures that you offer. So I really want to dive into that today.
Of course, my pleasure.
Awesome.
Where do you want to start?
Yeah. So I'm going to give the audience members a brief introduction of you, and then I want you to add if there are any other tidbits that you want to add, any other nuggets, I want you to feel free to add at the end. So today I have Emad. He's director of the Clinical Andrology Laboratory and director of the Male Fertility Research Program at the University of Miami. He has specialized training in male infertility and sexual medicine and works closely with the Miami Project to Cure Paralysis, where he focuses on improving fertility and sexual health outcomes for men with spinal cord injuries. And his research and clinical work really help bridge this cutting-edge science with practical strategies for optimizing men's reproductive health. When I was at the University of Miami in undergrad, I did research at the Miami Project to Cure Paralysis. So that place is amazing. Anything else you want to add to your intro, Emad?
It's actually a unique setup that is not actually present anywhere in the world except maybe there's a center in Sweden that also does especially spinal cord research. But there's only the very, very few centers in the world that do that. And the unique thing about the Miami Project to Cure Paralysis is that you can actually combine clinical research and basic research in the same setting. And through our talk, I'll explain a little bit about what happens to men after spinal cord injury and what we reached right now in our research capabilities and our changing basically from bench to bedside was helped by tons of basic researchers who helped us to get to where we are right now.
So I think this is a good place for maybe you to go into what some of your training looks like and how that evolves into you doing work at the Miami Project.
Yeah, it's an interesting journey because I finished medical school in Alexandria, Egypt. And I did like a combination of 6 years of urology and general surgery at the same time. So I did go in depth with the general surgery and the surgical techniques. And then I moved to the United States with my family. And I was always deeply involved in research, but because of lack of resources, you just could not really get into what you really want to accomplish. And I had the opportunity of doing, surprisingly, a pediatric urology fellowship here in Miami Children's Hospital. And they offered me the position, which was great to me because it has a lot of research potentials as well. So I did that. And I was trained to become a pediatric urologist. But for some reason, during that training, I don't know if I'm soft-hearted or no, but I could not really see all these children's sufferings under my hands. Cathing a 3-year-old who had a sarcoma in the prostate every single day for his chemo was kind of not my thing. So I figured, let me try to find something that has also research and at the same time would fulfill what I need to do clinically. And I was approached by two of the world pioneers in this type of research, Dr. Nancy Brackett and Dr. Charles Lynn. And it was a casual meeting in the AOA. And they said, why don't you come and join our group? And I said, I would love to do that. So they offered me the position and I did 2 years of postdoc fellowship, pure research. There's some clinical involved in it because the only way for us to do the research in spinal cord injury men is to do the physicals, get the ejaculate, and we're going to go in deeper on that, and then analyzing the specimen and then going through the research. So it was a great experience to me. And then I joined the faculty here at but I continued working on this research till they retired and I took over, and I've been the director of this program, and we evolved and we have lots of things that we're going to talk about.
Wow. So how long have you been at the University of Miami now?
21 years.
Wow.
Yeah. Been here for a long time.
Yeah, and I know that the talk amongst people in academics is it's really hard these days to really combine research with clinical work. Do you think in your space with spinal cord injury, like that's kind of like an outlier where it's just more common?
Oh, absolutely. And that was one of the conditions that I had when I joined the faculty, is like I want to continue doing that research and I want to dedicate time. Because if you don't dedicate time to this type of research, you will do, maybe good research, but it's going to be at minimal levels and you won't get to where I can get if I dedicate good time to it. So I have like 2 days that are solely dedicated to research. It's not purely research because I'll explain the way this mere fertility program works and how it was developed and how did I went on and progressed through it and did some additions to it. So I have a joint appointment with urology and neurosurgery, which is the main department in control of the Miami project. And the way that this program is set is that we have an evaluation clinic. And it's in one of the state-of-the-art new buildings, one of the newest buildings here at the university on the medical campus, which is the Christine Alien Rehabilitation Center. So it is a rehab center that has outpatients and inpatients and research. So we have like 2 floors dedicated for the Miami project, and I have an office here and I have a clinic here. So the patient, through either support groups or through a general intake forms and questionnaires that are sent to everybody who is diagnosed with spinal cord injury. One of it is if you're interested in checking your fertility status and your sexual dysfunction. We get patients that are interested, we approach them, we see them, we do an initial evaluation. So we do all the exams that are related to the spinal cord injury to find out the level of injury, sensory level of injury and everything, because that helps us. And we're going to explain how that this helps us in deciding which method they are better responding to. So in general, for the general audience who are listening to us, spinal cord injury is divided into, of course, cervical, thoracic, and lumbar and sacral. Most of the injuries are either the cervical or thoracic injuries. And when we test the sensations, and you're going to hear that a lot, we say this patient has spinal cord injury and he is, let's say, T5 complete. Well, what does that mean? It means that the last segment where the dermatomes, where he has the normal sensation, he or she has the normal sensation, is at the T5. Nothing below that. Complete means nothing totally. Incomplete, and then we divide that into, like, say, Asia A, B, C, and D. These are depending on the levels and the sensations, the sacral area. So if he has, like, it can be able to feel the anal contractions, do voluntary contractions, or has some sensations in the scrotum or in the penis, then he's incomplete. And then, of course, there are different categories. But this is, in a nutshell, what do we mean by when we say this is a level T5 attack. And of course, the higher you go, then you, instead of having a paraplegia patients, then we can have a tetraplegia patients where he cannot control both lower limbs and upper limbs. And of course, the higher you go, then the patients are on a ventilator. So these basically are the assessments that we start with. So we have specialized people here in the Miami project that will do the assessment for us, and we get that level. And then I'll do my urological exam, make sure that everything is okay. And just in general, for all the urologists listening to us, we treat them as if you're treating any able-bodied person. So we have to check with the testicles. We want to make sure that the normal volume. Maybe you get somebody with spinal cord injury, but he has a 3 cc testicle. Then that's something that we have to do. Hormonal profiles, we do a full exam. And then based on the level of injury, we start. So we have a protocol that we start with a vibrator. If it doesn't work, then we can do 2 vibrators, and I'll show you the examples of these vibrators and what we do. And then if it doesn't work, then we do electroejaculation.
Mm-hmm. And so these are for men who are actively trying to have a child or at least preserve sperm.
Yeah, so a lot of them are not really actively trying to, but they want to know their fertility status. Mm-hmm. So that's a pure evaluation. And then depending on what they really need, then we take them to the next step. Mm-hmm. Right. So, yeah, go ahead.
So how often do you think patients who suffer from a spinal cord injury are offered sexual and or fertility services?
Not a lot, unfortunately. And we've been trying to do some educational sessions in different areas. And I do a lot of lectures in the support groups to have them at least spread the word that there are things that we can help you. And believe it or not, I had a patient that came in and I said, I need something for my sexual dysfunction. And I asked my primary care to write a prescription for any PDE5 inhibitor. And the primary care looked at him and I said, why do you want this? You're young and healthy. And he told him, I have spinal cord injury. I mean, so even with the primary care field, not all of them know the consequences and the deleterious effects of spinal cord injury on sexual dysfunction. Mind as well, fertility part. They don't even know that part. Mm-hmm. And that actually, brings me to describing actually what happens after spinal cord injury for the things that can actually damage the potentials and how we are solving this. So any questions from you, or I can go in?
Oh, yeah. So right before you go into that, who are the typical patients that you're seeing? What is their mechanism of injury when it comes to spinal cord injury? Are these veterans or are these, pool and diving accidents?
So it depends. So causes of injury are actually depending on the demographics and the location where it is. So the geography of the country would change what is the most prevalent cause. So unfortunately here in Miami and South Florida, violence and gunshot wounds are number one. Mm. Then we have motor vehicle accidents. Diving will come in as well. And then falls are more common in certain parts of the country than here, but we still have falls. So these are the 4 main causes. Mm-hmm. So number one here, up to now, based on the research that is done every year, that gunshot wounds and violence are number one. Then we have motor vehicle accidents, motorcycle accidents are common as well. Diving is also a cause, but it depends. So if you go up north, then skiing accidents are more prevalent. Mm. Similar to diving here. So it's like, So the variations. So we have also strong connections with the VA. So we have a lot of veterans that come in because of war injuries and things like that. Mm-hmm. But in the general population, we see everybody.
Yeah. So let me ask you this, in terms of research funding, with that, really changing over the last, year, 2 years, 5, 10 years, where do you get your research funding for the work that you're doing at the Miami Project?
So right now, I was lucky enough before all the changes that happened that I have a 40-year grant from the U.S. Department of Defense for $3.25 million to test one of the medications that we're going to talk about to improve fertility in men with spinal cord injury. And then we have some types. So there are also organizations, but there's not a lot of money in there, but maybe 100,000 here, 200,000 here, that will help do the pilot studies that we take it from there to the big federal fundings. Mm-hmm. And we're hoping that things are going to get better so we can have more federal fundings. But right now, our aim is to do sideways. So I have this big grant, and then I'm sideways. I'm applying to get little pilot programs through other organizations and foundations.
Mm-hmm. Okay, so now why don't you get into what these patients are kind of presenting with and what you're doing about it?
Yeah, of course. So first of all, the problem with women with spinal cord injury don't have that issue. So the fertility potential is there. Nothing is affected. Conception is okay. No big deal. The only problem that they have, so in general, I'm going to use that term a lot. So it's autonomic dysreflexia. Mm-hmm. So what happens is above the level of injury for people who are T6 or 7 and above, so going all the way at cervical, if you have any stimulation below the level of injury, there are uninhibited sympathetic overflow that can cause bradycardia and can cause severe hypertension and flushing, headaches, and sometimes it's very, very dangerous. So with women, when they become pregnant and then the uterus gets bigger and then the pressure on the bladder while sitting on a wheelchair can cause this autonomic dysreflexia. So it has to be arranged for. Also, there are certain specs when it comes to labor and delivery, so they are considered high-risk pregnancies. But other than that, there's no issues. With men, it's a totally different ballgame. So they suffer from 3 main things that affects their potential for becoming biological fathers. Mm-hmm. The first one is erectile dysfunction. So ED is a common thing because it's urogenic ED. It's not vascular. Vascular flow is amazing. You do a Doppler on them, vascular flow is amazing. But the problem is neurogenic. So they have neurogenic ED. They get reflex erections, but they don't get the psychogenic one. There's 2 types of erections. So they get that. So the problem is they can initiate the erection, but they cannot maintain that. But that can be solved by using either the readily available PDE5 inhibitors, as long as we control for the hypertension and all this, depending on the level of injury, as we mentioned earlier. If not, a lot of them do ICI, intracavernosal injections, and it works beautifully for them. But we have to also adjust for depending on how they can use their hands. So the dexterity is important. So if they can't do the injections, if they are quadriplegics, then if there's a partner and can do the injections for them, then they can do that. Mm-hmm. But it works also very well with them.
So let me ask you this. Because we know that the PDE5 inhibitors, when someone has a neurologic injury, especially like, let's say after prostate cancer and their nerves are still recovering, they're less likely to respond to the PDE5s. Are patients with spinal cord injury, do they respond similarly like in this case?
So yeah, if they can initiate the erections and then use the PDE5s, that will maintain it for a longer period of time. Yes. Mm-hmm. And and it works. And sildenafil has been used extensively, and there's a lot of studies in there, and it works. Tadalafil as well. So it's been used and it's been proven. And I have a lot of patients that use it on because they can initiate, and that just puts them into the level where they can maintain it for some time. Mm-hmm. But it's not going to initiate.
I gotcha. Do you find with penile injection therapy, because I've had a patient with spinal cord injury and he responded to an extremely low dose of it. So do we need to dose lower in patients with SCI?
Yeah. You want to make sure that. And also remember, that's the whole trick about that is because there's no release. So they don't ejaculate. Mm-hmm. So they can have extended time of penetrative intercourse, but there's no release, so they will still gonna maintain the erection. So we usually make sure that they have a very, very low dose, start with a very low dose, and then maybe progress, but you want to make sure that they are controlled.
Mm-hmm. Now, let me ask you this. What about the use of erection rings? Because I think some people might be concerned if they can't feel how tight it is, they won't know if it's too tight. So that's fair game.
That's one of the things that I personally don't like to use VEDs and rings in men with spinal cord injury because naturally, because of the extended period that they can have with intercourse, then they tend to whatever they're done, they sleep.
Mm-hmm.
And they totally forget about that there's a ring in there that can cause damages. And then they wake up in the morning and then the damage is already done. So I really don't like it unless I have a very well-educated patient that is very aware of the situation and can really control the desire to sleep after having sex and then leaving that in there.
Mm-hmm.
So that is like, I personally don't like it. I would rather have them do ICI or use that.
Mm-hmm.
And then, of course, last resort, like everybody else, if it doesn't work, then we have the IPPs or the semi-rigids, and all these things are personal preference and also depends on hand dexterity. Because you can bend and stretch even if you have poor hand dexterity, but you can't use the pump.
Mm-hmm.
So if you don't have a partner, a regular partner that can do that, that sometimes would be an issue.
Mm-hmm.
And then, of course, because the calf, they use intermittent catheterization all their lives, so they're prone to getting infections. One of the issues as well would be getting infectious, especially epididymal orchitis, and then we go into the problems with the implant as well.
Mm-hmm.
But mainly that's for the sexual part. So it's been studied and we can solve that part. The next one is the ejaculatory dysfunction. They don't ejaculate. We have maybe 5% of patients with spinal cord injury that can masturbate and give a sample. 95% of them cannot. And that's where these devices come into the picture. And so let me show you first. So this is the Ferticare 2.0, which is currently the vibrator that has been studied and approved. And we have a study that was published comparing this to the older device, and it was very successful. And that's the one I'm using all the time. But remember when we talked about the level of injury? Any patient who is T10 and below, the success rate is very low with this. T10 and above, you have about 85 or 86% success rate. So that vibrator, I don't know if it can be seen here through the camera. So this is the most important part. And I come to the question about why don't we use any other vibrator? This is the amplitude, which is the distance that this head travels up and down between the penis and the device. There's a lot of studies that are done by medical engineers, a lot of PhD, like really researchers that are interested in finding out why. And they found that the 2.5 millimeters, that's the distance that this head travels, is the optimal one to produce an ejaculation. Down here, this is the frequency. Usually put it on the max. And then what happens with this is what it is. So that's the penis. We just put it here, dorsum. Okay? I'm going to just put this so that we can hear it. So this is dorsum right there. I prefer that because you can collect easily there with a cup, or assistant holding a cup. But some people would ejaculate more when it's on the frenulum, so we just do that. And that's this. Okay? If they don't respond with one, but I see some spasms, which is the trick to if it works or no, then I can use two vibrators, which is called the sandwich technique. One at the frenulum and one at the dorsum. And then based on the study that we published that shows that the sandwich works, a developer thought about it and looked at his wife's hair straightener and then decided to do this Vibrect. This is the newest model of the Vibrect, which is the Vibrect Pro, right? So it also has the same thing. It has frequencies that you can adjust. And then when you bring them together, then it vibrates. So I'll just show you as an example. See it. Yeah, so you have same thing. You put the penis here, and then you collect at the tip. So that is the Vibrect. that if you don't have two vibrators, you can use that one, and then you can alternate. So here you can use the top one, you can use the bottom one, you can use the two together. So you can switch.
Price-wise, where do these typically run at?
So this vibrator runs about, for the patient, it's going to be about $850, $900.
So would the patient buy it and bring it into the office, or you have these?
No, I have mine here and I use, and then these pads are changed. You can just remove it and use it. So I have a lot of pads, and we can do that, and you can clean it. It's as long as there's no abrasions or wounds on the skin, or penile skin, then you can use that one. This one, this is new. I'm not sure what is the price for, but there is a website that anybody can go to, because before that we used to require a prescription in order for you to get a vibrator. Now it's an OTC. You just can buy it on the website and go there. I think it's a men's urology health store or something like that. I'm not sure. I can send you later the link, and then you can put it in. So they have all these vibrators and they sell them. So my protocol is doing single vibrator. If it doesn't work, then two vibrators or the Vibrect. If it doesn't work, then we do electroejaculation. And that is the advanced step. With men with spinal cord injury, if they have complete injuries, so meaning that there's nothing in the sacrum, then we can do that in the office and they don't feel it. So this is the device that we're talking about. All right. So here, just explain. All right.
So Emad, how often do people, I know you've taught a lot of courses on this technology, how often do people who even specialize in male infertility get taught about EEJ?
Not a lot, unfortunately. Yeah. Maybe if they're trained here in our program, then they know, because they come and can join me in the clinic and see that. Or I do a lot of EEJs also in the OR for let's say men with psychogenic ED and ejaculatory dysfunction. So there's a lot of psychogenic and ejaculations that we see depending on the culture and where they're coming from. So we do that in the OR. Diabetics who cannot, and also some of the SCIs who are sensate with some sacral sensations, we do that in the OR. But the majority of them we do here. It's very simple. It's easy. And we always say that this is 100% guaranteed to get you an ejaculate. The only difference is we say nearly, because of the ones that we talked about that has some sensation. So we have to take them to the OR. But if we take them to the OR and we just do constant sedation or very light mat, they respond right away. And I've done a lot of these in the OR, and we get the results, and we get good specimen that would at least can be used without going to your last resort of doing the TESAs or TESIs. So we just can do that, and we get a good sample, and we usually cryo them, or sometimes even we send them straight to the reproductive endocrinologist, and they use it right away. So we do that in the morning of retrieval, and we just send it right away. All right. So basically we have volts here. I don't know if it's clear or no, but this dial is volts, and this dial is milliamps, and this is the temperature setup, and the machine is designed to shut off when it reaches 39 degrees. And so that it avoids rectal burns and injuries. And this is the probe that we have in there. And as you can see, there are 3 electrodes in there. They should be facing prostate, and each one of the top ones are facing the seminal vesicles. And the way we know it, because what's it inside here, this is the blue line that should be aligned with the spine. So we know then that this is facing the prostate and the seminal vesicles. And of course, because there's no resistance, you won't see the dials. So we have a testing device. So this is a testing probe. This is not used in humans. This is just testing. So that when you look at the dials here and I move that, they both in. So the way that it works is we just go slowly with the volts. And I usually go like maybe 2 or 3 volts and then go down to 0. And then the assistant would collect. And then you go up again and try and go down, down till you get to the point where you have a good ejaculate, and that's it. One of the issues with the electroejaculation is a possibility of retrograde ejaculation. So we always prep the bladder before. So we empty the bladder, we install sperm wash medium in there, and then we do this. And if there's retroejaculation and you collect it, you have good sperm survival because it's not urine, because urine is toxic. So you can't do any cryopreservation with that. But if it's done properly and the bladder is prepped, then you will be able to at least preserve that. So this is, in a nutshell, what we do in the clinic to assess fertility potentials for any patients that come in there with spinal cord injury.
So I looked at that website that you were mentioning. It is urologyhealthstore.com.
Yeah.
And they sell the Vibrect, and it's $395. So it's not too bad.
No, yeah, the Vibrect is like one of the reasonable options. If somebody wants to try it, then yeah, you can do that. You can use the Vibrect. The only thing is like, it requires like a learning curve. This one is very simple. You just put it in and that's it. But of course, price-wise, this is more expensive. This one, yeah, just learning curve till you get to the idea of how to and collect. So people can at least try at the beginning without the intentions of collecting. And then once they are trained to it, then you can use that. Yeah, it's a cheaper option.
So let me ask you this. In the setting of a guy who doesn't have spinal cord injury, have you found tools like the Vibrect to be helpful in those guys?
So you have to lower the frequency and the amplitude, or it's going to be painful. So the way it was designed initially was also for penile rehab after radical prostatectomies or any pelvic surgeries that patients develop ED after that. Then they use that for penile rehab. You lower the amplitude and the frequency, then it's not going to be painful and can work. And there's a lot of programs that do this and try it. So it sometimes works. It's like, the trick with the penile rehab after prostatectomies specifically is like, you don't really know if things are going to get back or no, but you have to try it. And which is the best thing is to try early, start early.
Do people find it pleasurable, or it's just you want to do it so it's comfortable but not painful? Like, does it feel good?
For who?
Oh, for
or for
let's say it's part of penile rehabilitation.
Penile rehab, yes, it is. A lot of patients will feel it like it's pleasurable because it's unless you bump up the amplitude, and that is gonna be really painful. But if you lower it, yeah, and actually sometimes even. So the patient that I just had now, he's incomplete injury. So he has some sensations, which is interestingly enough, he had sensations on the right half of his penis and not on the left one, and on the right testicle and not on the left one. And when I put the vibrator on, it felt very pleasurable to him. Because at the beginning, I thought that it might be painful, so I warned him. And then he goes, no, it's real. And he was like closing his eyes, and he was very happy with that.
Yeah.
So it's variable, but yes, yeah.
Yeah, because I certainly think vibrational therapy can be helpful for men. I mean, I had one patient that uses a wand like this and just puts it on his penis. This is a guy who he's probably in his 70s, no history of spinal cord injury. He loves it. He loves this for arousal and to increase his erections. And then I'm just thinking kind of like a rabbit vibrator. If you put the tip of the penis in like here, then you're kind of getting that clamping action too and could feel.
Yeah. No, yeah. No. I mean, for the only, as we mentioned earlier, the only problem is if you are doing the vibrator on SCI to get an ejaculate, the problem with these low amplitude vibrators, they don't reach the maximum amplitude that you want for the ejaculation. But interestingly enough, when the program started, these vibrators were not existing. So they were using all these massages, and people would do it. And when I give a lecture, I always have a slide that is so funny because one of the 31st patient in the program got a potato head vibrator and it worked for him. And he was like, that's the only one that works. He puts the feet of the potato head, puts the vibrator on, and it works. So yeah, I mean, whatever works is great. Science sometimes maybe over-exaggerates things, maybe, but the science is there with the amplitude distance.
So, are there any men with spinal cord injury that you feel like you can't help with your current technologies and tools?
Yeah, if they have, so I can't help if we don't want to go the extra step. So technically, let's say in Europe, where it's social medicine, yeah, I can easily take the patient to the OR. Actually, they do most of the EEGs, even if the patient has spinal cord injury and doesn't feel anything. They take them to the OR and do it to have 100% guarantee that they're going to get it. But over here, we have to weigh it's like cost effectiveness, right? Go to the OR with anesthesia and the cost of all this. Which one is actually going to benefit the patient? Because you're going to go through this. If the patient wants it, I do it all the time. But if the patient feels like insurance is not going to cover it and he's going to pay out of pocket, shall we do just a TESA and look at it and that's it? Or we take them to the OR? So that is the only time where I feel like I can't help the patient. Or if the patient is coming from out of town, or sometimes I have people coming from out of the country for me to do that for them. And if I need to take them to the OR, they don't have insurance, so it's going to be like, yeah. Luckily, it doesn't happen a lot because we need to do the assessments and everything, but it happens. And I feel like we can't do that, and I just refer them that we have to do something in the office. We do a TESA, and then we'll work through it.
Now, how often are these men with spinal cord injury also presenting with infertility issues related to other reasons, not their spinal cord injury?
Oh, that's what we talked about earlier. If you see a patient with spinal cord injury that gets an ejaculate, and we have to talk about that because that's where the research is coming from. So if you see a patient with azoospermia, then you treat him same way as you treat any able-bodied azoospermia. You do a hormonal profile, you do the exam, you do everything. You want to make sure obstructive or production, all this same. But if your patient with SCI, that's the unique picture that is different than any able-bodied fertility. Most of the time, when you see oligoacinozoospermia, you see low counts, low motility, low everything. With men with spinal cord injury, you see normal count even higher than normal. You see millions of sperm, but the majority of them are non-motile and non-viable. So, prospectively, if you let's say think 40% or above as good motility, you get maybe 5, 8%, 10%. I mean, you can rarely get into the 20s. And that's one of the major issues. And that is years and years of research till we got to the point that the inflammatory process is what's causing this. A lot of cytokines are secreted in there. And the study that I'm doing right now is testing probenecid, which has been used for gout for many years and not used anymore. But we found out that there's a molecule called the inflammasome, and that's where the basic scientists come and help us with that. So we did a lot of studies on the sperm cells or on the semen, and we found that these cytokines are secreted by a main multi-protein complex called the inflammasome. This inflammasome causes secretion of cytokines when it's activated, and we found that this probenecid blocks a cell wall channel called the pannexin 1 and prevents the inflammasome from being activated. So we take going all the way upstream. So we did a pilot study and we found, that probenecid helps with having these cytokines less effective, less secretions, and improves the motility. And based on that, we submitted the DoD grant and we got it and we're doing it right now. Wow. So we're studying. So it's a double-blinded placebo-controlled study where we're doing placebo, we're doing half a dose of probenecid and a full dose of probenecid, and we're all blinded. We are blinded, the patient is blinded, nobody knows what it is till we're done with the study, and I'm blind.
Emad, how difficult is it to do a placebo-controlled double-blinded study?
Very difficult. And it's even harder for recruitment. Because patients like to, I want to get the treatment. And even if I promise them, if everything is good and it's effective and you are on the placebo arm, I'm going to give you that, but in 4 years. It's very tough. A patient, I want something now. It's not easy. Trust me, it's not easy at all. And especially with the current situation and everything, it's kind of like very, very tough. Which we're getting patients and everything, but we can't get to the numbers that we suggested, because before that we were able to get that. Now the patients are kind of reluctant to be involved with things like that. But it's not easy. Definitely not easy.
So maybe for urologists watching who see some infertility patients or men with spinal cord injury, what are the inclusion criteria they should be looking out for in case they are a candidate?
18 years and older with spinal cord injury, period. We will do all the investigations. And of course, if you know upfront that he has azoospermia, then, but I'm sure with spinal cord injury, they're not even tested. So we'll take it from there. Just refer them to us and we will take care of everything. And all the assessments and everything and the hormonal profile that we do are part of the study. The patient has no cost whatsoever, $0. So, and that would be great.
Local, or they could be from anywhere around the country.
From anywhere. We try to get them local, but right now we are in the process of if somebody from out of Miami, like anywhere in the country, wants to be involved, then they're willing to come because there's a lot of visits. Mm-hmm. If they're willing to come and will pay the costs, then more than happy to accommodate them.
Mm-hmm. So the last topic I want to delve into is just on like typical cryopreservation, because I think that's a topic that a lot of people, they don't really understand what that infrastructure and the steps look like. And you have something very cool set up at the University of Miami where you, as the director of the lab, are also meeting with the patients. So you could go through, because now I've sent you actually a couple of patients where I have guys that they're like, maybe at some point in the future, I may want to have a child, but right now I want to be on testosterone therapy. I feel much better on therapy, and it's only a slim chance in the future. I want some peace of mind. So what should we be telling patients in terms of abstaining from ejaculation, and what does that visit look like with you and your clinic?
Yeah, so it's very simple. So what we try to say is like 2 to 5 days of abstinence, stay on a healthy diet, and then the few days before coming in, well hydrated, just water, just drink a lot of water, and come in. There is no specific supplements or things. Some can help, but if it's a short period of time between they wanted to make the appointment and come in, I don't think that it's going to be very helpful. And then my admin assistant, once he gets the information, the patient gets registered at the UHUP system, and 2 appointments are made with me personally. One of them is for the collection. So they come into the office in a private room. They will have a cup that they will collect the semen in, and then they will let us know through texting services. So it's all purely private. Nobody's going to knock on the door. Nobody's going to go in. They collect. We get the sample from them. I have them wait outside for the next appointment, which is the consult. We look at the sample, we get the numbers, and then I bring the patient in and I explain to them everything in detail. So spend about 20, 25 minutes discussing everything and answering all the questions. And I usually like to start by explaining to them the total motile sperm count, because that is really what matters. And that's what's going to decide if they're going to go to IUI or IVF, because these are the only two that a thawed specimen after being cryopreserved will be used at. So you can do home insemination. So it's either IUI or IVF. And I always like to, and that is the main difference in our setup, because I understand this part. So I'm not just a technician who, okay, these are the numbers and pay this and go. I always judge by looking at the patient's age, the situation, if he's in a relationship or no, how soon they want to do that and everything. And then I would suggest, okay, we have enough. You don't need anything. We have 10 vials and each vial has 10 million total motile. You can easily combine 2 for an IUI. You'll have 8 left. So don't worry about that. You don't need to have additional. Or sometimes I have a patient who has very low volume with decent numbers maybe, but not enough. So I always like to have more vials. So I would tell them, we need to have an additional. We'll cryopreserve this one. Come for additional visits depending on when you want to start. Like say if he's going to be on TRT, before you start TRT, come over and we'll have additional till everything is done. And we do that also for oncology, for cancer patients. And that is, patients with TRT, we can easily manage. They can suffer a little bit till we're done with that. But with cancer patients, I don't have the luxury of telling the oncologist, please delay your treatment till I get enough samples. But I would love to, and I sometimes force them to do that. If I see that the patient is very young and he was kind of anxious and he couldn't get a good volume, then maybe next time, my experience, I know the next time he's going to get more volume, or if he's very young and things like that. Mm-hmm. But that's basically what happens. So the patient leaves the room. I always put a prescription for it because we need to do an infectious disease panel. So I give them a prescription for that if it's not done already.
And can you explain why you need those results?
Okay, so if an IVF doctor is going to use that specimen, it has to be linked with these labs to make sure that it's non-infectious. That's the first thing. That's the most important thing. Because people sometimes confuse, yeah, if it's going to be paying more, I'm going to pay more. No. The problem is, if it's not linked, 99% of the IVF doctors, the REIs in the country, are not going to touch that specimen. So you want to make sure that it's HIV non-reactive, Hep B, C, and syphilis as well. So we do also IPR. So it's important that we have that in the panel attached to that, and that's what we have to do. It has to be within the same period of time that the specimen was collected. On the other side, when I send it to long-term storage, or if I store it in my lab, I have to do this in a special, if it's infectious, but so it's potentially infectious, right? I don't know what it is. So I have to store it somewhere different. And the long-term storage, they have to store it on vapor. So it costs more. So they charge more than double what they usually charge. So currently the rate is $395 a year. Then they will charge a lot more than that, close to $800, something like that. So it is just do a simple blood draw and that's it.
But that's important for people to know. One, so they get the blood draw. And two, even if one of those comes back positive or reactive, they can still cryopreserve.
Oh, yes.
Things need to be in place.
Yeah. It's just only, so let's say, for instance, an HIV positive sample, it has to be stored in a different way. It has to be frozen separately. And then the IVF doctor will do separate things for that particular specimen based on the consents and everything, but it can be used. It has a certain way of washing and everything. Mm-hmm. It's technical, but can be used.
Yeah. So let me ask you this. How often do guys come in who are on testosterone therapy and are azospermic?
Oh, a lot. We have a lot of patients that are on treatments and they come in and then they realize that I want to check and see. And sometimes even some of them don't think about it that way. So one of the questions that we always ask in our intake form during the visit is any medications, and we stress on any supplements. Because sometimes people take supplements from outside, not prescribed by a doctor, and they think, it's natural, it's nothing, and then it has testosterone in it. Mm-hmm. And that can cause this, especially people coming with supplements from other countries. Mm-hmm. They don't know, and they think it's natural, and then they find out that it has T in it, and it's causing that. Some of the patients, their body doesn't react that bad to it, and you can have some sperm in there. So it's not 100% rule, but the majority, they come azospermic.
Yeah, that's what's interesting about testosterone is I know some people who have had several children on testosterone therapy and not even on things like HCG, and other people that are completely azospermic, when they're on testosterone. So the only way to know, is to check. All right, another question here. So we're in sunny South Florida, and I'm sure a lot of people are always at the beach and in the pool and in the hot tub. How often do you feel like you're seeing lower sperm counts related to saunas and hot tubs?
I mean, it depends on the frequency of it. Mm-hmm. So if you go into the sauna maybe once a week or something, or sit in a hot tub, and that it's not really causing that damage. But if it's an every single day thing and for extended period of time, that can cause some damage.
Mm-hmm.
Yeah. I mean, I've seen it. As you mentioned, here in Florida, it's something like cool. Let's say, yeah, you go to a spa and you sit in there and you do all this, and then you're already on the beach for like 5 hours in the sun. So it is like an extra effect.
Mm-hmm.
Yeah. The dartress can work for certain limits, but you're overstretching the dartress work. So it's like,
Yeah.
it is, yeah.
So I guess maybe the moral of the story there is if someone is actively trying to conceive is to maybe lay off the sauna for a bit.
Yes, absolutely. And even with spinal cord injury, we ask this question.
Uh-huh.
If you do that frequently, because some of them would feel like the bowel program or that they help when they sit in there. So we want to make sure that it's not a regular thing that they do.
Yeah. Okay, another question here. So being in South Florida, there are a lot of, let's say, older men who are with younger women and having children with younger women. Do you see a lot of men, let's say, in their 60s who are looking to expand their families?
60 is young.
60s young?
60 is young. We see all that.
Tell me more about this.
Yes. Yeah. It's very, very common. Actually, it's very common here in South Florida.
Yeah, I heard this rule. I don't know who came up with this rule, Emad, but that it's like a man's age divided by 2 plus 7 is like the ideal age of his female partner.
No, that I never heard of that, but that's interesting. That's very interesting. Yeah.
So
they even have an equation for it. That's great.
what would you tell a guy who comes in who's, let's say, in his 70s who has some infertility issues? How do you help him?
So the whole point is we try to give them some data about paternal age effects.
Mm-hmm.
But regardless, I mean, if they want it, it's the choice. We just work through the same setup as everything. And then we also advise that when you go, if you're going to do it naturally, then make sure that you're tested genetically before and your partner or your wife is tested and everything. So it's to make sure. If you're going to do IVF, they will take care of that. But if you're going to do natural, then that's what it is. But it's very, very common. Absolutely. When I first moved to Miami, I was like, oh, first patient and the second patient I saw in the couples, and I said, wow. And then after that, it's becoming natural. So when we have new fellows and new residents and they start getting surprised, and one of the things that we always say when we teach our residents when they first join our fellows, especially if they are from other parts of the country, like more of the conservative section of the country, we always tell them, when you go into the room, don't ever assume that the female inside is the daughter or the wife. We don't. Because a lot of them fell into the trick of like say, and that's your daughter. And it's like, no, it's a partner. So always respect whatever is there. If you want to ask, you can ask the question and you are something like generic, but don't assume that. Yeah.
Well, I've learned to ask, who is this lovely person that you brought with you today?
Oh, yeah, that's right.
Forget to offend anyone saying that. You know, the other question I always ask my male patients, regardless of their age, is are you interested in current or future fertility when they're coming to see me for testosterone? Because I make no assumptions, because every now and again, someone who's in their 60s, who's a prime candidate for testosterone says, actually, I would like to consider fertility.
You know how I approach that? I always tell them, ask a simple question. You have a checking account. Do you have a saving account? And they say, yes, I have a saving account. I said, that's your saving account for the future. Mm-hmm. You're just gonna cost you like $400 a year? How much money do you spend on going on a nice dinner? So right now with the current economy, you can easily spend that on a dinner for 2 and a bottle of wine. Might as well have this for the whole year in there. You don't know. And also with the current like laws and changes, we've seen that a lot with the vasectomies. Mm-hmm. So we always advise young people who don't have any children, please, cryopreserve your sample before the vasectomy. Mm-hmm. It's a simple, easy thing you can use in the future. And then if you decide in the future that you don't want it or you want to do a vasoreversal, it's up to you, but at least you have that.
Mm-hmm. Yeah, I ask all my vasectomy patients beforehand if they want to.
Because we have lots of young people now coming for vasectomy.
Yeah.
With no children in their 20s. So it's like, you don't know how even you're going to think about living arrangements in 10 years. You're still 20 something. So, yeah.
So there are a lot of companies that are coming out with at-home semen analysis testing. As director of the fertility lab, what is your take on the lab testing that you do and the at-home testing?
I'll give you an example, that an analogy outside of this. Think about you go into a fancy restaurant and the chef is like cooking the food in front of you that is fresh. Let's say you're eating seafood and it's right coming out of there.
Yum.
You can see the food right in front of you, fresh and nice, and you eat it. And you go to another restaurant where he pulls off a frozen piece of fish, put it in. At the end, it's going to taste the same, but the quality is different. When you have a specimen that is collected right in the same place where it goes from this room to the lab across the hall, left to actually in an incubator for some good time, and then tested thoroughly by technicians who are trained very well into doing this under microscope right away, and then you get the results on the same day.
Mm-hmm.
Then getting a home kit. It's very convenient. Don't misunderstand me. It's very convenient for a lot of patients who can't really come into that. But we always say, worst case scenario, if you really can't come in and collect because you don't have time, if you can collect at home and bring it within an hour, we'll still do it and with no effects on the integrity of that. Mm-hmm. But in order for me to do in this same hot weather that we talked about for the Saunas, it's going to go through UPS or FedEx. These people are not that highly, I would say, technical in understanding what is the specimen. So they're going to throw it away with everything else. Maybe it's in a box. Yeah, it is safe, but it's going to stay in the sun for like then the tamarack on the airport for like another hours and hours. And it's going to go there. By the time it gets there, it has a preservatives and it's been tested and everything. But also some of these companies would just put it into a custom machine, get the reading, and then that's it. You're not going to get a complete picture of what you're looking for. And then naturally, there are going to be some errors. Mm-hmm. So minimizing the errors when you do things in an actual lab has trained people in there, and I am there. No results come out of my lab without me making sure that everything is done properly. Mm-hmm. And then we have quality control every day, proficiency testing twice or 3 times a year. I mean, we do a lot of the controls to make sure that everybody that is testing these specimens is really very well trained. But when you send it somewhere, you don't really know. Yeah, maybe the director of this lab is qualified, but you don't really know who the people do that. It's the same as Quest, let's say. If you find a location that will accept semen sample, have you ever seen a report coming from Quest? The report comes in this way. Motile sperm specimen. And that's it. It's a single line. I mean, what do I benefit out of this? Or vasectomies. It's even worse. No sperm or sperm, and that's it. I mean, I just need something. Was the volume adequate or no, right? These are the little things that are different when you do it in a professional lab and outside. If you have a vasectomy sample that the patient is giving me 0.1 ml, I'm not going to clear her, even if there's no sperm. Because that's a very, very low volume. That definitely, I'm not sure actually if that's a true ejaculator or no, or if it's something that maybe he spilled something in it. So, no. But if you send it anywhere, nobody's going to tell you because you don't see the volume even in the report. It's just like whatever. It's that it is. So it's helpful. It's a good resource. But if the treatment really relies on this, I think you should at least give your patient another chance of doing it somewhere else with professional setup, so that at least you can compare.
Yeah. And I would say my algorithm has changed a little bit after speaking with you. And I think that's what's really important. If we're going to refer someone to another provider in our area, sitting down with them to understand what that process looks like. Because I've sent a couple patients to you, and one in particular said it was seamless. I went in, they took me back, we did the visit, I got the results right away, I left. I've spoken to you about the cost. The cost is actually quite similar to the at-home testing. So for a lot of people, it's not going to be, cost prohibitive or much more than the at-home testing. And the results that you get are going to be better. So that was very helpful for me to understand.
And we try as much as we can to make it not like the regular doctor's visit, where you go in there and you stay in the clinic, wait for 2 hours before somebody sees you. A lot of times, if I have availability, I would see them before even that appointment. And we'll put them in a room, we're collecting everything. So it is like, so all of them would come in and I say, that's the first time I've ever seen a doctor before my appointment. It never happened before. So at least we try as much as we can to make it within reasonable time, even if we're delayed a little bit, like maybe 15 minutes, 20 minutes, something like that. Try as much as I can to do it within the time frame.
Yeah. My last question for you, what currently excites you about the field of fertility?
Oh, there's a lot of things really that are, but to be honest with you, the one thing that I really would love it to get to the finish line is the prepubertal testicular tissue preservation. Because I see a lot of young children and young boys, adolescents, that I can't do anything to them. We have the program and we with Pittsburgh and everything, but we're still not there. They're doing great work. But if we get to that point, that would be amazingly helpful. And then, of course, if we combine AI with biomedical engineering and everything, then we can develop a nice testis that would produce sperm. That will be a dream come true with the tissues that are available, but at least try to make it work a little bit. It requires, but science is going in a very nice space. So it's like, yeah, let's hope that these things we can see in our lifetimes.
I love that. Well, we're going to stay tuned.
Definitely.
Emad, it was so lovely having you on Pearls and Perspectives today. Thank you so much for sharing your expertise. It is so awesome to hear about what you're doing at the University of Miami. And I'm going to continue sending patients over you because you have expertise in all these different areas. And my patients are looking for the person to go to in South Florida.
Thank you so much, Amy, for inviting me. It's been a pleasure. And we're always there to help all your patients and everybody who's listening in the area. More than happy to help.
Thanks, Emad. And thanks, folks, for tuning in today.